Welcome all. Today's talk is about Green Top Guideline number 27A. It is on Placenta Previa and Placenta Accreta diagnosis and management. The guideline is published in September 2018. So we begin with our quote, Master MRCOG with concept-oriented clarity. So we'll clarify our all concepts from this particular guideline with respect to the Placenta Previa and Placenta Accreta. Most of the time, the questions will be asked on this particular topic. Okay, so what are the risk factors for the placenta previa and low-lying placenta? So as usual in the green top guideline, there is always an executive summary which is given. So we'll cover first the executive summary, and this will be followed by the detailed discussion on each point. Okay, so the risk factors for the placenta previa will include prior cesarean section, and there is an association with the number of cesarean sections. More the number, more is the risk for the placenta previa. Okay, and also association with ART is known, assisted reproductive technology, and maternal smoking. So apart from these risk factors, that is a previous history of cesarean section, assisted reproductive technology, and maternal smoking, what we need to remember here is the number of cesarean sections, because there will be question on this SBA. We will go into the details in subsequent slide. Okay, so what are the methods for the screening and what terminologies are to be used? Okay, so normally during routine anomaly scan in mid trimester, we have to look for the placental localization. So placenta previa will be equal to the placenta which is covering the internal os. So the what terminology we will use? Placenta previa when placenta is covering the internal os. And what terminology when we will use or the low lying placenta is used when the placental age is less than 20 millimeter from the internal os, and it is done after 16 weeks of gestation, either by transabdominal or transvaginal route. Okay, so these two terminologies, when we use the word placenta previa, when we are going to use the word low-lying placenta, so placenta previa is the placenta which is covering the internal os. Whether it is partial, complete, forget about it. It is a placenta previa. When the placenta is within 2 centimeters of the internal os, either by TAS or TVS after 16 weeks, we will say this as a low-lying placenta. Scan. What is the next step? Again, this is a question. Anomaly scan, and it is low lying or it is a previa at that time. So what will be your advice? You need to repeat a TVS at 32 weeks. Okay, it is TVS at 32 weeks. Now, if the placenta is persistent at 32 weeks and the patient is asymptomatic, then we will repeat again TVS at 36 weeks to guide for delivery plan. Okay, so first is a mid-trimester placental localization. Find out whether the placenta is previa or the placenta is low-lying. Then repeat a TVS at 32 weeks. If it is still persistent, then we will repeat at 36 weeks. Okay, and we will plan the delivery accordingly. So TVS is safe and superior to the transabdominal and transperineal scans. So additionally, what we can assess? What we can assess is cervical length. Okay, so you can do the TVS before 34 weeks, and if you find the short cervix, then the short cervix is associated with increased risk of preterm emergency delivery and massive hemorrhage at cesarean section. So short cervix before 34 weeks in placenta previa is associated with increased risk of preterm vaginal delivery or preterm emergency delivery and massive cesarean section, massive hemorrhage during cesarean section. What care is required in the third trimester? Now, it will depend upon whether your patient is symptomatic or whether patient is asymptomatic. And the care will be either hospital care or it will be home care. Now, let's see in which condition what care is recommended. Now, this particular, if your patient is having recurrent bleeding, the care should be individualized, either home care or hospital care, which will be based on the distance from the hospital, availability of the transport, history of previous episodes of bleeding, and other lab parameters, willingness for the blood transfusion, etc. etc. If the patient is admitted, all admitted patients need to undergo VTE risk. Okay, venous thromboembolism risk. This is also one of the important guidelines. At least 8 to 10 questions will be there on this particular guideline. We will have a separate session on this. Okay, so if the patient is admitted, assess for VTE risk. Okay, then if the patient, can you unmute yourself, doctor? If the patient is at home, you need to give a clear advice to attend immediately with any bleeding, pain, and contractions. So the patient should be compliant with the advice, and they should be warned that they will report to the hospital if there is any bleeding, pain, or contractions. Now, if you have a asymptomatic patient, in that particular case, the home care is going to be sufficient. So, but you need to counsel on the risk that there are chances of preterm delivery, there are chances of hemorrhage, and they need to report to the hospital, or there has to be easy hospital access. Okay, the cervical encirclage is not recommended outside the clinical trial. Okay, so there is no role of cervical encirclage in placenta. Now, what are the risk factors? And again, we will have the whatever we have discussed up till now, we will summarize it. So risk factors we have seen: previous cesarean section, assisted reproductive technique, maternal smoking. Now, screening and terminology we have discussed. What is placenta previa? What is low-lying placenta? Previa is covering the os. Low-lying is within 2 centimeter or 20 millimeter from the internal os. If previa or low-lying is at anomaly scan, then we will repeat the TVS at 32 weeks. If it is persistent and asymptomatic at 32 weeks, then we will repeat TVS at 36 weeks to guide the delivery, and TVS is safe and superior to the transabdominal and transperineal scan. Okay, so if we are given these particular TVS, TS, they'll give you the same option. The mid-trimester annual scan, the finding is placenta previa. What will be next step? It may be TVS at 32 weeks, TVS at 34 weeks, TVS at 32 weeks, TAS at 30 weeks, transperineal at 30 weeks, etc., etc., etc. So the next step will be TVS at 32 weeks. Okay. So what additional assessment? Cervical length you can assess. If it is a short cervix, there will be increased risk of preterm delivery as well as hemorrhage during cesarean section. Now, third trimester care also we have seen. Either it can be home care or hospital care. Okay, for asymptomatic cases, home care is sufficient, but we have to counsel them regarding the risk. And for hospital care, better the hospital care will be given if it is a history of bleeding. Okay. Now, placenta previa low-lying, what kind of delivery and intrapartum management is required? Now, antenatal steroids, when antenatal steroid routinely should be given at 34 to 35.6 weeks of gestation. And if there is a risk of preterm birth, in that particular case, we'll give at 34 weeks. Okay. So you remember that particular flow: mid-trimester anomaly, placental localization, low-lying, 32 repeat TVS, 36 repeat TVS. Before 30, after 32 TVS, you are going to give steroids 34 to 35.6 weeks of gestation. If she is a high risk for preterm, give steroids before 34 weeks of gestation. Okay. What is the role of tocolysis in these particular cases? It will be considered. It is mainly for allow the action of the steroids for 48 hours. Otherwise, do not use if the delivery is indicated for maternal or fetal concerns. So tocolysis per se has got limited role, and it is mainly for the action of the steroids. Now, what is the timing of delivery? 34 to 36.6 weeks is the preferred timing if there is a history of bleeding or risk factors. Okay, so 34 to 36.6 weeks is the preferred timing for the delivery. And if it is uncomplicated placenta previa, you deliver between 36 to 37 weeks of gestation. So if the case, or if the patient is having recurrent episodes of bleeding, or if she has got other associated factors, then you consider the delivery between 34 to 36.6 weeks of gestation. Okay. Otherwise, in uncomplicated plain placenta previa, you consider between 36 and 37 weeks of gestation. What will be the mode of delivery? Vaginal delivery may be considered if it is asymptomatic low-lying placenta. Okay, but the decision will be guided by the TVS placental age to head distance and the clinical background, maternal preference, etc., etc. So, asymptomatic cases, you may allow delivery for low-lying placenta. Okay. Pre-delivery counseling, we need to talk about blood transfusion, need for hysterectomy, and massive hemorrhage. Okay, document any refusal of blood products. We need to talk to them and take the history of whether they are Jehovah's Witness or not. If they are refusing the blood transfusion, we have to explain the other alternatives. Okay, then high risk for women, especially women who have atypical antibodies, we need to involve hematologist and blood bank early. Okay. Then about anemia prevention, we need to screen and treat the antenatal anemia in the antenatal period. Senior staff, if it is a case of planned cesarean section, it is the senior most anesthetist and senior most consultant will be there. Okay. And if it is an emergency cesarean section, then senior team member should be available. Okay. Whoever is available, the senior most person will be there during the cesarean section if it is an emergency. Planned is always a consultant. Okay. Then anesthesia, regional anesthesia is preferred. Okay. That has got a that reduces the hemorrhage risk. Then it may be converted to general anesthesia if required. We need to take a consent accordingly. Blood and transfusion support, ensure and liaison with the transfusion lab, have rapid infusion and warming devices, and cell salvage if high risk of the blood and there is a refusal of transfusion. So cell salvage option can be considered in those patients who are refusing the blood. Okay. Surgical approach, if you have a case which is less than 28 weeks of gestation, or if there is a transfer slag, in that particular case, you can take a vertical skin and vertical uterine incision. Okay. So, but it is mainly if the gestational age is less than 28 weeks and it is a transfer slag. Okay. Intraoperative and surgical considerations. So, preoperative and intraoperative ultrasound, sometimes it is helpful, because what happens if you delineate the placental age, you can take the incision accordingly, you can avoid the placenta. Okay. If you do the preoperative ultrasound, if the placenta is transected, go for early cord clamping. Okay, because it will reduce the fetal blood loss. If the bleeding persists despite of drugs, then use intrauterine balloon tamponade and or surgical hemostasis. Okay, so these patients will be prone for the development of the PPH. We will manage with appropriate drugs. If fails, then go for intrauterine balloon tamponade and or surgical hemostasis. Interventional radiology should be used urgently if it is available and possible. Okay. If measures fail, then proceed early to hysterectomy. Now coming to the placenta accreta spectrum. What are the risk factors for placenta accreta spectrum? Previous history of placenta accreta spectrum, previous cesarean section, the risk increases with the number, prior uterine surgery or repeated curettage, and women choosing elective cesarean section for non-medical reasons should be counseled about placenta accreta spectrum risk. Okay, so elective cesarean section has got a risk for the development of this pass. Okay, then what is the antenatal diagnosis? It is actually the suspicion that is very important. So antenatal detection will reduce the morbidity and mortality. So if you are dealing with a case of previous cesarean section and the placenta is anterior and low lying, or it is a previa, then we need to suspect this placenta accreta spectrum. And ultrasound has got high accuracy in skilled hands, and refer to the specialist unit if features suggest placenta accreta spectrum. MRI is almost comparable to the ultrasound, but it is helpful mainly for the posterior placenta or parametrial invasion. Okay, so the MRI role is in these cases, placenta accreta spectrum, is to find out whether the placenta is posterior or is there any parametrial invasion. Okay. Now, in which care setting these patients should be delivered? It is always going to be the hospital delivery, consultant-led unit will be there. Okay, women with placenta accreta spectrum should be managed in a specialist center with multidisciplinary team. Facility for the blood products, ICU and ICU is required, because it has got a high morbidity, mortality, high chances of preterm. So NICU, ICU, blood products are going to be important, and expertise in complex pelvic surgery is must. Okay. Then what is the timing of delivery? Okay. For placenta accreta spectrum, it is 35 to 36.6 weeks. Okay. If no additional preterm risk. What we have seen in placenta previa, 34 to 36.6 weeks if it is associated with recurrent bleeding or high risk in our previous slide. Okay. And if it is asymptomatic, then what we have seen, 36 to 37 weeks of gestation. Now we are talking about placenta accreta spectrum, the planned delivery between 34 to 36, 35 to 36.6. There it was 34. Here it is 35 to 36.6 weeks. Okay. And contingency plan for emergency delivery must be in place. Okay. Now, what we are going to discuss with respect to the consent, counseling, and what kind of team will be involved, that we'll see. Okay. So we need to talk about massive obstetric hemorrhage, urinary tract injury, blood transfusion, higher risk of hysterectomy. Additional measures in massive hemorrhage will be considered cell salvage and interventional radiology if possible. Team for elective cesarean section, always it is a multidisciplinary team involving senior anesthetists, obstetricians, and other surgical specialties if required. For emergency, the most senior clinician available should be involved. Anesthesia of choice, regional anesthesia can be given because it reduces the risk of hemorrhage, and it may be converted to GA, so we need to inform the patient accordingly. What is going to be the surgical approach with respect to placenta accreta spectrum? Preferred is a caesarean hysterectomy with placenta in situ, left in situ. Okay, so it is a caesarean hysterectomy with placenta left in situ is going to be the preferred option. The other conservative measures will be occasionally used. That those are the alternatives, like the uterus preserving surgery, like partial myometrial resection. Only if there is a limited invasion and accessible. In that particular case, you can think of uterus preserving surgery, but routinely preferred will be caesarean hysterectomy with placenta left in situ. Okay, so and this uterine preserving surgery needs to be attempted only by experienced teams after full counseling and consent. Ureteric stents not routinely required, but it may help in bladder invasion. Okay. Now coming to the placenta Accreta. Okay, so we have seen placenta previa, low-lying placenta management. We have seen placenta accreta spectrum. Now it is a placenta Accreta. There is a limited evidence for uterine preservation. In placenta Accreta, again, uterine preservation almost no role. Okay, high risk of complications in placenta when we think about uterine preservation. Okay, so women should be counseled accordingly. Expectant management will be placenta left in situ, but when in which case we are going to think about this? This is option for women who refuse hysterectomy or where hysterectomy is inappropriate. Okay, so these are the cases where expectant management will be followed. That is, a placenta will be left in situ. It requires close monitoring and review by ultrasonography, etc. And methotrexate is not recommended. Okay, and in placenta Accreta interventional radiology, there is insufficient evidence for routine use. Now, if your placenta accreta spectrum is diagnosed, undiagnosed or unsuspected, how we are going to manage? If it is a case of elective cesarean section, and if you find placenta Accreta which is discovered, you can delay the delivery until appropriate staff and blood resources are ready. May close abdomen and transfer to the specialist. Sometimes they can give you the scenario that it is an emergency condition and you have opened the such and such patient with gravida 2, para 1, living 1, previous lower segment cesarean section, and the placenta was anterior, and you open the abdomen and you find that there is a placenta accreta. The consultant is 20 minutes away. Okay, and you are performing, or the registrar or the ST5 is performing a cesarean section. What will be your close the abdomen or proceed with this, that, etc., etc. So the option will be call the consultant, because senior most person is required, and we have not yet started. We have opened the abdomen and we have not taken any incision. So it will, the scenario, you need to select the most correct option. Okay, so such kind of EMQ, if you get, you need to know this particular guideline very carefully. So if the placenta Accreta is discovered, delay delivery until appropriate staff, blood and resources are ready. So if you have an option that confirm the availability of the blood, wait for the consultant to come, and that can be an appropriate option here. Generally, the closing the abdomen when in a well-equipped setup, this may not be, but if it is a secondary setup, but such questions generally not asked. Okay, so after birth diagnosis, you can leave the placenta in situ and perform emergency hysterectomy. Okay, now coming to the detailed guideline. Placenta previa and placenta accreta, these are the major causes of maternal and neonatal morbidity and mortality. Incidence is increasing due to rising cesarean section, increased maternal age, assisted reproductive technology. Okay, and if worst outcomes occur if diagnosis is made only at delivery. So it is always, if you diagnose these conditions accurately, the morbidity is going to be reduced, mortality is going to be reduced. So now placenta previa diagnosis, this is going to be the whole repetition what we have seen. it is a mid trimester. Can anyone, Dr. Sinchana, can you summarize regarding this placenta previa screening by ultrasound, what we have discussed?
They're usually identified during routine mid-trimester scan,
Yeah.
usually after 16 weeks TBS scan. If there is a placenta previa low lying, we'll repeat the scan at 32. We repeat TBS scan at 32 weeks. And
Okay.
if the patient is still low lying and asymptomatic, we'll again repeat the scan at 36 weeks.
Yes, yes, yes. Okay. So, what they expect that when you do the mid-trimester animal scan between 18.6 to 21.6, we have to localize the placenta. At that time only, we need to find out and screen these patients for a placenta previa. Okay, and then you follow that particular protocol, and the mode is a TBS. Okay. Now, this older classification is not used. Okay, this is a transabdominal based older classification, that is grade 1, grade 2, grade 3, grade 4. Minor when there is a lower age in the lower uterine segment, marginal when it touches the internal os, partially covering the os. So instead of that, what we use, either it is a low lying or whether it is a previa. Okay, so it option will be either there is no low lying placenta, or there is a low lying placenta, or there is a previa. Okay, so these are the terminologies which we should use as per AIUM, that is American Institute of Ultrasound Medicine. That is placenta previa. Placenta is directly over the internal os. It may be partial, it may be complete. Okay. Then low lying, when the placental age is within less than 20 millimeter from the os, and normal is 20 or more. Remember, if they give 20, then it is normal. Okay, so 20 or more is normal. Okay. The clinical relevance will be, it improves risk stratification for antepartum hemorrhage and management of the major PPH. Incidence at term is around 1 in 200 pregnancies. Risk factors for cesarean, risk factors are prior cesarean, ART, advanced maternal age, etc. Placenta accreta spectrum, it is abnormal adherence of the placenta to uterine wall due to absent or deficient residue. So this is what is actually the pathology, where there is an absent or deficient residue. Now, spectrum of invasion may be accreta, increta, percreta. We know this because accreta has got a villi which will be attached to the myometrium superficially. If it is a deep myometrial invasion, it will be increta, percreta. It can perforate the serosa and invade into the adjacent organs like bladder also. So clinically, it may be focal or partial or total involvement, and often coexistence of different depths in the same case. So it may be the depth of penetration may be different in the same case. Now, diagnostic challenges. Difficult to distinguish from the retained placenta without histology, because ultimate diagnosis will be on the histopathology only. Okay, so prevalence varies around 1 in 300 to 1 in 2000 pregnancies due to inconsistent definitions. Terminology like morbidly adherent placenta, it is outdated. So preferred term is a placenta accreta spectrum. Okay, so when you have the this placenta invasive placenta, you say it is a placenta accreta spectrum. Okay, so clinical outcomes, placenta percreta maternal mortality was reported around 7% in 1990s, but nowadays outcome is improved. Okay, so clinical aspects, key clinical aspects are early TBS diagnosis is important. It reduces the complication. AIUM classification more clinically useful than older grading. Okay, so these are the points you should remember. Placenta accreta spectrum disorder, it may be adherent or it may be invasive also. High risk women will require a planned multidisciplinary management in tertiary centers. Antenatal diagnosis and care in placenta previa and low lying placenta. Now these are the risk factors for cesarean section. Risk factors cesarean section, it is a dose dependent. We have seen one of the factor for this placenta accreta spectrum is a cesarean section, and these are the different relative risk with respect to cesarean section. Generally, they do not ask these relative risks; they ask in terms of percentages. But just I have taken it out. Up till now, they have not asked. But relative risk with one cesarean section is a 4.5, with two cesarean section is a 7.4, with three cesarean section it is a 6.5, and a four or more cesarean section it is a 44.9 risk of pass. Okay, so as the cesarean section cesarean section number increases, the relative risk for development of the placenta accreta spectrum also increases. So such kind of SBS they can ask. And these are the other odds and relative risk which are mentioned with respect to ART is how much with respect to smoking, but generally these are not asked. So I'll skip this particular slide rather than making it complicated. Okay, but the slide will be available for your reading. Okay. Now screening and follow-up routine fetal anomaly screening around 18.6 to 21.6. We will localize the placenta, and after that, as per the definition, whether it is low lying, normal, or previa, we are going to follow them up at 32 weeks and further at 36 weeks if it is persistent. Okay. How many percentage will be resolution by term? So 90% of the low lying cases resolve before term. Okay. By 32 weeks, 50% will resolve, and by term, 90% will resolve. And the resolution is less likely if it is a case of prior cesarean section. Okay. So this can be asked as a how many percentage of the cases the placenta previa there will be resolution. So 90% by term, 50% by 32 weeks. Okay. Now, what is the role and safety of TVS? We have already seen the TVS is safe. Okay. So if you do the TAS, transabdominal, but and further you do the TVS, most of the or 26 to 60% of the low-lying cases can be further identified if you carry out TVS. Okay. So if you initially do the TAS and repeat TVS, then almost 26 to 60% you need to have a reclassification. Okay, that is why TVS is very important. This sensitivity specificity we will not go. We have also seen that the cervical length measurement has got a significance in placenta previa. If you have got a less cervical length in that particular case, there is an increased risk of preterm caesarean section and the massive hemorrhage. Okay, if your cervical length is less than 25 millimeter, relative risk is around 7 for massive hemorrhage. Okay. So these are the key clinical pathways, takeaways. Prior caesarean section, ART, smoking, maternal age, these are the main risk factors. Placental site must be assessed at anomaly scan and repeated TVS at 32 and possibly at 36 weeks. TVS is safe, accurate, and essential for diagnosis and management planning. Cervical length on TVS helps to predict hemorrhage and preterm delivery risk. Okay, is it clear? Is it clear up till now?
Yes, sir. Yes, sir.
Okay, yeah.
Yes, sir. It's clear.
Good. You could join, doctor. I'm glad. I was.
Thank you very much.
Yeah. So now let's talk about care of women with low-lying placenta and placenta previa in the third trimester. Okay, women with recurrent bleeding, the care will be based on. See, this also we have seen there is going to be either hospital care or there can be home care. Now, those who have recurrent bleeding, preferably hospital, but it will all depend on the distance from the hospital, number and severity of the bleeding episodes, hematology results, and acceptance of the blood transfusion. Okay, hospitalization, consider if there is a recurrent or severe bleeding, and once hospitalized, always VTE risk. Never forget VTE assessment once the patient is hospitalized, even if it is hyperemesis. Okay, those patients will require VTE assessment and will require thromboprophylaxis for the duration of hospitalization. Okay, here it will be different in different cases. Okay, if managed at home, they must attend hospital immediately for any bleeding, contractions, and suprapubic pain. Okay, no clear advantage of hospital versus home care if it is a asymptomatic case. Okay, predictors for the emergency cesarean section: if there is a history of sentinel bleed before 29 weeks of gestation, 3 or more antepartum hemorrhage episodes, prior cesarean section, and antenatal blood transfusion. So these are the predictors for emergency cesarean section in these cases. Okay, so if we are dealing with low-lying placenta, placenta previa, and if there is a history of bleeding before 29 weeks of gestation, or there are more than 3 episodes of antepartum hemorrhage, or it is a case of prior cesarean section, because they are less likely to resolution. Okay, but because we are dealing quite early in the gestation, okay, they are likely to stay like that only, and these patients are likely to have an emergency cesarean section. Okay, now if you have asymptomatic women, we need to counsel them regarding the risk of preterm birth and obstetric hemorrhage, and home care is feasible in this particular case, provided they understand that they need to report to the hospital as early as possible. Okay, so the persistent risk factor, prior cesarean section, uh, 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 and small distance distance placenta to us, thick placental age. So these are actually the risk factors for the hemorrhage also. If it is a recurrent bleeding, consider hospitalization VT assessment. If it is asymptomatic, outpatient care is sufficient. Okay. Now we continue with the care of the women with low-lying placenta and placenta previa. So the same slide is there. Slide is repeated. Okay. Now what are the neonatal outcomes? So there is high chance that the low Apgar score will be there. NICU admissions chances are high. Anemia, respiratory distress syndrome, ventilation, IVH. These are the risk which are increased. There is no increased risk of SGA. There is a role of antenatal steroids always. Okay. So what is the gestational age at which antenatal steroids we are supposed to give? Yes, what we have discussed in the initial
34 to
discussion.
35 plus 6 weeks.
Yeah, we need to give by around 34 to that particular time
35,
this
week 16.
antenatal corticosteroids. But if it is a high risk case, then before 34 we have to consider. Okay, antenatal corticosteroids. That is, I think, third or fourth slide we have seen. Okay, benefits is that it reduces the prenatal death, RDS, IVH, and NEC. Then late preterm 34 to 36.5 weeks of gestation, betamethasone will reduce the or it will reduce neonatal respiratory complication. Best strategy is to give steroids at 35.5 weeks and planned delivery at 36 weeks. Okay, so around 35 definitely you need to give these steroids. Then clinical points are recurrent bleeding, hospitalization, VT assessment. This all we have seen. There is just repetition of few points. So tocolysis in asymptomatic placenta previa, the role is only short term tocolysis is for the action of the steroids. Okay, so that is what is we have already seen. Now the timing of planned delivery. Okay, with respect to the bleeding and the risk factors, we'll consider the delivery between 34 to 36.6 if it is a case of recurrent bleeding. Okay, if it is a uncomplicated case, then delivery between 36 to 37 weeks of gestation. So whatever these timing of delivery we are discussing, please make a separate chart of it. At the end, we will have all the timings. In which case, what is the timing of delivery? Maybe in twins and all, we'll have all discussion together as the exam will be nearing. But now just start segregating these timings because you get confused during the examination. Okay, so placenta previa, recurrent bleeding 34 to 36.6 weeks. Asymptomatic case 36 to 37 weeks. Okay, now what is the risk of hemorrhage with respect to the gestation? Okay, I don't think this has been asked up till now, but I just found it I should include, so I included in presentation. So the risk of hemorrhage will increase as the gestation advances. Okay, because we are talking between 34 to 37 weeks, then 36 to 37. Why this? Because if she is a case of recurrent bleeding, then definitely the chance of bleeding will be more as we continue the pregnancy. So at around 35 weeks of gestation, near about 5% or 4.7% chance of hemorrhage is there. After 1 week, it will be triple, that is 15%. Then it doubles. Every weekly you see it doubles. Okay. So at 35 weeks, you remember 35 you have a 5%. Then 36 weeks, it will become 15%. Then 37, it will become 30%. And it will further double, that is 59 or 60% at around 38 weeks of gestation. Okay, this has not been asked. The neonatal risk, earlier delivery, increase NICU admission, low Apgar scores, etc. etc. Okay, vaginal delivery in low-lying placenta will depend on with respect to individualized case and the TVS findings, placental age to os distance that we have seen. This will be only in low-lying placenta it is possible. Okay, in placental age should be less than 20 millimeter from the os. Higher cesarean section, high cesarean section need if the placenta is thick, more than 10 millimeter, spongy, or has a marginal sinus. So if you on ultrasound these features are there, then higher chances of cesarean section even in low-lying placenta. So low-lying placenta, this vaginal delivery is an option, but in that also higher chance of cesarean section if your placental age is thick or has got a marginal sinus. Success of vaginal delivery, placental age around 10 to 20 millimeter, and it varies between around 60 to 90%. Okay. Then optimizing delivery in placenta previa. Discuss the delivery plan with the patient. You explain everything, all risks which are involved, like blood transfusion, hysterectomy, etc. Take into account the patient's wishes for the blood products. Obtain informed consent as per the guideline. Delivery setting, it is always a maternal unit with on-site blood transfusion facilities. Critical care facilities should be available. And anterior low-lying placenta increases the risk of massive hemorrhage and hysterectomy. Higher risk groups, women with atypical antibodies always involve hematologist and the blood bank. Okay, prevention and treatment of antenatal anemia is essential. Now, risk of hemorrhage, there is high chance that you are going to land up with PPH or the blood loss more than 1000 during cesarean section if you are dealing with a placenta previa cesarean section as compared to other cesarean section. Okay, the relative risk is 4, so 4 times high chance of PPH or the blood loss more than 1000 if you are dealing with a cesarean section of placenta previa. Okay, anterior placenta and previa over the was independent risk factors for massive. These are the independent factors. Okay, and odds ratio is around 3.5 to 4.1. Maternal hemorrhagic morbidity is 19% versus 7% in non-previa cases. So these minor percentages are not asked, so no need, but just remember the PPH chances are high. Okay. Now, blood management. Risk of massive hemorrhage is 12 times high as compared to other cesarean sections. Screen for anemia. So if you have got less than 11 gram hemoglobin at booking or less than 10.5 at 28 weeks of gestation, treat the anemia with iron. Okay. For high risk women, Previa without antibodies, weekly group and screen is recommended to keep compatible blood ready. Okay. The delivery of women with placenta previa and low-lying placenta. The planned cesarean section, senior obstetrician, senior anesthetist. Emergency cesarean section, senior most team member should attend the delivery. Okay. Trainee as a primary surgeon will have higher risk of maternal complications. Okay. So complications may happen if it is associated with the fetal malpresentation, and generally this requires complex maneuvers, and that is why the senior most obstetrician is important. Regional anesthesia may be given, but we may have to convert it to GA, and that we need to talk to the patient before. Okay. So for the blood and blood product, always liaison with the blood bank is required. Cell salvage is recommended if the blood large fetal blood loss is anticipated. Then packed red cells, FFP, cryoprecipitate, fibrinogen, this should be ready. And post-operative hemoglobin less than 7, you need to consider transfusion. Okay. And in emergency, we will give O negative blood if the group is unknown. Okay. Then surgical approach, less than 28 weeks, transverse lie, vertical incision over the skin as well as uterus. Use pre and intra ultrasound to guide the uterine incision. If placenta is transected, suppose you cut through the placenta, you clamp the cord immediately. Okay. Otherwise, routine cesarean section, vaginal delivery, what we go for delayed cord clamping. We had a total discussion on one of the SIPs last time, so I have already uploaded that. Please listen that again. Okay. If for hemorrhage, early use of tamponade, hemostatic sutures, interventional radiology. If it is not controlled, proceed for the hysterectomy straight away. Okay. Hemorrhage control methods, there is a balloon tamponade and success rate is around 75 to 88%. The compression sutures, you can go ahead. Interventional radiology like embolization, temporary balloon occlusion, etc. So these are the techniques which we need to use. Now here are the questions on this particular slide. Now these placenta accreta spectrum, what is the risk and diagnosis? Okay, so this placenta accreta spectrum, the risk is increased with when there is a previous history of elective cesarean section. Okay, so women should be counseled about increased risk of placenta accreta spectrum in future pregnancies if the patient is undergoing elective cesarean section. Then association with the cesarean section is known. Okay, there is increased risk 7-fold after one previous cesarean section. Okay, placenta previa as additional risk factor, risk of placenta previa, placenta accreta spectrum with placenta previa plus cesarean section. Here, these are the frequently asked questions. Okay, percentages. Generally, in first 15 to 18 SBAs, you will have the question on this. There is a history of 3 previous cesarean section, and the chance of having placenta accreta spectrum is this. Okay, so 1 cesarean section, it is 3%. 2 cesarean section, there is 11% chance. With 3 cesarean section, there is a 40% chance. With 4 cesarean section, there is a 61% chance. And 5 or more cesarean section, there is a 67% chance of development of the placenta accreta spectrum. Okay, so these percentages they can ask you. Okay, and it is always a number of cesarean section. The risk will go on increasing from 3% to 67%. Okay, so these risk, you can take the photograph of this particular slide. Then other risk factors: advanced maternal age, adjusted odd ratio. AOR is adjusted odd ratio. It increases by 1.3 per year. Okay. ART also increases the incidence of placenta accreta spectrum. Okay. And for other uterine surgery like curettage, manual removal of placenta, adjusted odd ratio is around 3.4. Okay. Then ultrasound screening to be performed by the skilled operators, good sensitivity. Key signs for this are the placental lacunae. It shows a moth-eaten appearance, loss of clear border to uterus interface surface, and abnormal vascularity on color Doppler. Okay. TVS is most useful, especially for cesarean section scar with pregnancies. Depth and extent assessment is limited. No sign reliably differentiate adherent versus invasive types. Okay, so whether it is just adherent or invasive, only expert is it is not always possible to comment. That is what they want to say. But here there is a role of MRI, especially in these cases. Okay, so if you have, what is the role of MRI in placenta accreta spectrum? USG versus MRI. What the guidelines say is similar diagnostic value when it is done by the expert. So if the USG is done by the expert, it has got same value as MRI, but MRI is useful or the complementary to the ultrasound for the depth and extension of assessment, and especially in posterior placenta or suspected parametrial invasion. So that you can there is an advantage for the MRI especially. The MRI features will be abnormal uterine bulging, dark T2 intraplacental bands, heterogeneous signal, and disorganized vasculature, loss of uteroplacental zone. Okay, sensitivity is 75 to 100%, specificity is around 65 to 100%. Now, care setting for placenta accreta spectrum: specialist center with multidisciplinary team, blood bank, ICU, NICU, pelvic surgery expertise, manage postpartum hemorrhage. This all we have already discussed. Okay. Then timing of delivery in placenta accreta spectrum, it is between 35 to 36.6 weeks of gestation. Corticosteroids are indicated, okay, in these cases. And delivery planning in suspected placenta accreta spectrum, general planning, there has to be emergency contingency plan. Okay, optimal management depends on expertise, extent of invasion of the placenta previa, imaging, comorbidities, etc. Main risk is a massive hemorrhage, and needs massive transfusion. Okay, what is massive transfusion? When more than or equal to 8 units are required, and massive hemorrhage can lead to coagulopathy and organ failure and death. Okay, and there are high chances of hysterectomy in these patients. Now, when you are taking the consent, you need to talk about the routine cesarean section risk. Then, with respect to placenta accreta spectrum, we'll discuss about the risk of hemorrhage, transfusion, hysterectomy, urinary tract injury, etc. Discuss possible interventions like cell salvage, interventional radiology. So, you need to remember when to use the cell salvage, especially. Okay. The senior obstetrician must review antenatally and document the plan in records. So this plan has to be recorded in advance, because you have diagnosed, and we have already seen in the beginning that if you diagnose this particular condition antenatally, morbidity and mortality is very, very less. Okay. Options are conservative management versus hysterectomy if increta or percreta is confirmed. If patient is refusing donor blood, transfer to unit with cell salvage. That is what is the importance of cell salvage. Okay. Now, preferred is a cystectomy, conservative wherever indicated. Okay. Multidisciplinary team involvement always. Okay. Now, optimizing delivery and surgical approach. The preferred approach is a cesarean section with hysterectomy, cesarean hysterectomy with placenta left in situ. That is the preferred approach. Okay. It avoids and always avoid attempts at placental removal. If you attempt placental removal, 100% chances of hemorrhage, and no doubt there will be hysterectomy ultimately. But so don't remove the placenta. Go ahead with the hysterectomy with placenta left in situ. If limited invasion and accessible site in that particular case, uterus preserving surgery, that is a partial myometrial resection can be tried. Okay, if you have a localized or limited invasion of the placenta, in that particular case you can try this partial myomectomy and the uterine preserving surgery. Okay, and this is to be done by expert teams with full counseling. Ureteric stents routinely not required, but if it is a bladder invasion, that can be used. Okay, so attempting placental removal, there is a 100% hysterectomy, nearly 100% it will end up with hysterectomy. Elective cesarean section with hysterectomy is safer than emergency removal. Uterus preserving surgery success is 63%. Secondary hysterectomy is required in 30%, and maternal mortality is around 3 to 4%. Okay, then it is actually the triple P procedure that you need to pre-delivery, you need to localize the placenta, then intraoperatively the pelvic devascularization and non-placental non-separation. These are the triple P which you need to carry out this placenta accreta spectrum that will reduce your hysterectomy chances of PPH and the hospital stay, because you go ahead electively cesarean hysterectomy with placenta left in situ. Okay. Now surgical approach for placenta accreta. Okay, there is again here there is a limited evidence for uterus preserving surgery, high risk of complications. Secondary hysterectomy is possible. The options available are go ahead primary hysterectomy, no placental separation. Okay, then fetus is delivered avoiding the placenta and keep the placenta in situ. Third is a local resection of implantation site and do the uterine repair. And next is a fetus is delivered, placenta is left in situ, and elective hysterectomy is done 3 to 7 days later. But the preferred one is a cesarean hysterectomy. Okay, primary hysterectomy with no placental separation. Okay, so rest of the things are I won't be complicating the things, so I will not go into minor details. But you should remember primary cesarean section with no placental separation. Expectant management not very common, but that can be considered when hysterectomy is unacceptable or inappropriate. It requires regular review of ultrasound and emergency access. Methotrexate is not recommended. Okay. Now interventional radiology also has got a limited role. Evidence is limited, and it reduces the intraoperative hemorrhage. Okay. Management of undiagnosed or unsuspected placenta accreta at delivery. Now you have diagnosed, or this was up till now undiagnosed, and you are come to know that it is a placenta accreta spectrum during delivery. If the placenta accreta is found intraoperatively, mother baby is stable, you can delay the cesarean section until appropriate staff and blood products are and resources are available. This we have discussed in the beginning. Okay, it may require abdominal closure and urgent transfer to the specialist unit. If the placenta accreta spectrum is diagnosed after the delivery, leave the placenta in situ, perform emergency hysterectomy. If the placenta fails to separate, safer to leave in place with or without proceeding to hysterectomy. Forced removal, there is a massive hemorrhage, high morbidity, and chances of death are also increased. We have seen 100% chance of hysterectomy. So the clinical governance aspect is mainly important for part 3 candidates. So you have to do the debriefing, training, and incident report. Okay, so that finishes the topic of placenta previa and placenta accreta.